All right. So yeah, I'll just try to get as much as I can by 2 o'clock, and then wherever we stop, that'll be all the quiz content.
It is
Yeah.
2. It didn't 3.
3?
I was confused.
3. We've got a lot to cover. All right, so we are still looking at plaque-induced gingivitis. We talked about some hormonal variations, but I also want to touch on some systemic conditions as well, okay? So it's interesting to see this correlation between systemic issues and gingivitis, because a lot of the times the mouth is going to be the first sign, okay? So this is why it's important to note and document these things. So as you guys know, leukemia is a cancer of the body's blood-forming tissues, usually involves the white blood cells. And typically, if the patient has gingivitis and also has leukemia, we will see that exaggerated inflammatory response, even if there's a little bit of plaque present, okay? So we're talking about, there's only a little bit of plaque present. The amount of inflammation doesn't make sense relative to the amount present. Does that make sense? So what we may see in this, we'll see increased bleeding and tissue enlargement, okay? So as I said, sometimes you as the dental professional, you may be the first one to suspect that something's going on, okay? I'm gonna give you guys a couple of examples. We had a patient here. Seniors have what's called like a mock board exam, right? Had a gentleman, super nice, but he sat for us and just wouldn't stop bleeding, right? I remember because I was the third examiner. This is not stopping. We put gauze, got one stack done, got another gauze stack there. It was not bleed, it didn't stop. So I called the doctor over and she said, I think it's just necrotizing gingivitis. That's why he's not stopping. So she put Hemodent on there and kind of just made sure there wasn't trauma. Long story short, a few months later, found out that the patient died of leukemia. Yes, which like gave me goosebumps because he was super nice, and this was just 2020, last year. He was in his late 30s, right? So there, we saw a lot of bleeding, didn't understand why, but it was also someone who had not been to the dentist in 15 years, right? So it could be other things. It could be, you know, necrotizing this and that. But for him, it ended up being leukemia. Okay, so just to kind of make that connection, right? We are oftentimes the first ones to see this. I remember we found diabetes in a patient because we were like, this doesn't make sense. You're pretty clean in here. Why is it bleeding so much? Go to your physician. Thank you for telling me I have diabetes, and it's pretty uncontrolled, right? So oftentimes oral lesions will be that first sign. Yeah.
Did you guys make like a referral for his medical doctor, or it was just like after he was bleeding a lot to get that leukemia diagnosis?
Yes, a referral for sure. Exactly. Leukemia-associated gingivitis begins in the papilla, spreads to the margin and then to the attached gingiva, but other signs, like I said, we see increased bleeding, increased swelling too. Okay, how the tissues may look in a patient. So swollen, spongy, shiny, and red to deep purple in color. Another good word to know is friable. So SSGG, that word. What that means is the tissues will tear easily and bleed really easily, which makes sense for that patient, right? That's why we thought it was NUG, which is that necrotizing ulcerative gingivitis, because his tissues look like that. So you have to come up with like this differential diagnosis, if that makes sense, okay? All right, another systemic condition that has an obvious effect on gingivitis, okay? So plaque biofilm accumulation, we will see this exacerbated response with gingivitis. Smokers actually have fewer clinical signs and symptoms of gingival inflammation than non-smokers. Kind of interesting, right? Some of you wrote about smoking and gingivitis or perio disease. Does anyone know why we see less clinical signs?
It depresses host response.
Yes, so depression of the host response, there's a few other reasons too.
If smoking causes vasoconstriction?
Yes, vasoconstriction is another one. And also if this patient's been smoking for a really long time, you have that fibrotic tissue also masking whatever inflammation. So this kind of blew my mind. I was like, smoking, you would think, super inflamed, but it's actually the opposite, okay? One of those characteristics we say, the fibrous tissue kind of concealing the inflammation, gingival fibrosis, okay? more to come on smoking. It's a pretty big topic, so that's why I put a little note there. But this is just so you know there is that correlation with gingivitis and smoking. Okay, malnutrition in plaque-induced gingivitis. So as a systemic condition, if someone is malnourished in any way, that can also have an effect, okay? The biggest one that seems to always come up is vitamin C deficiency. You might have learned this in preventive as well, right? So one of the major deficiencies that has good documentation is ascorbic acid gingivitis. So that's the term you might come across. So ascorbic acid gingivitis, meaning they have a depletion in vitamin C, which is not good because vitamin C helps with collagen, it helps with fibrous tissues that support the teeth, the bones, connective tissue, all of that, right? Also, with lack of vitamin C, the patient will have delayed wound healing, okay? How do you think that's gonna play a role if someone is malnourished with vitamin C in their mouth?
Gingivitis.
But what about it? What happens if they have gingivitis or periodontitis and we scale?
They're gonna have a lot of bleeding.
And what else?
Longer to heal.
Longer to heal. So if you bring them back for an evaluation, their pockets still might be deep, right? They'll still be bleeding because of another factor. Very good. All right, so here is what malnutrition, ascorbic acid deficiency gingivitis will look like. I like this picture a lot, okay? I like to compare it to pyogenic granuloma, okay? And who do we see pyogenic granulomas in? Pregnancy. So how is this different from pregnancy? More generalized, very good. So these swollen papillary regions, it's more generalized. Whereas the pyogenic granuloma or the pregnancy tumor was more localized.
And that could be a male, right?
Yep, male, female.
No, but I mean but the pregnancy one. Is...
Oh, yes. yes, I see what you're saying, yeah. Okay. Additionally, what makes this different from the pyogenic granuloma, do you guys see this kind of yellow crusty, right? So ulcerated gingival tissues as well as like a yellow kind of golden crust on the lips as well. All right. Yeah.
Do these like occur from one day to the next, or does it start off small and does it get that big?
It depends. It can be acute. The onset can be really quick, or it can be a gradual thing. But usually, if they like get a vitamin C supplement, it resolves really quickly, which is a good thing. Yeah. Okay, some other oral factors to consider, those restorations, right? If it's a faulty restoration, meaning, who can give me an example of a faulty restoration? Overhang, open margin, right? Open contact, right? That can be a detriment with gingivitis as well because we're accumulating a lot more plaque and bacteria, okay? And then we're gonna talk about hyposalivation, right, or xerostomia. Obviously, the dryness of the mouth, we don't have that cleansing effect of the saliva, which is important to get rid of some plaque and bacteria. It can also make the patient feel uncomfortable, so they don't take care of their mouth, which just makes things worse. And then we want to look at things that are possibly causing that hyposalivation. Medications, health conditions, poorly controlled diabetes, anxiety, things like that. Okay. All right, and then we have gingival enlargement as a result of certain medications, okay? So are these filled in for you?
No.
That must mean it's really important then, right? All right. So we have anticonvulsants, calcium channel blockers, sometimes I'll call those CCBs, and immunosuppressants. CCBs and immunosuppressants. Obviously, we know with medications, there's lots of different side effects, but here we're focusing on gingival enlargement specifically, okay? And these three particular categories you need to know. This class, for your board exam, it'll show up time and time again.
I know that you said you like CCBs. Does the board like CCBs?
They'll call it no, so the boards will, what I've been seeing right now, because I've been doing like the practice sim exams, they are giving, it's hard. They'll give you the generic brand name or the brand name, and then you have to figure out what category it falls under and what it's treating. So they'll say, here's Zoloft, what category is that, and what is it treating for the patient, and what are the side effects?
That's cool.
Yeah, it is cool. So that's why you have pharmacology next term. But for this class, in this moment in time, I just want you guys to know the categories, and then we'll talk about specific examples of each so you know what to look out for, okay? All right, we good on this slide?
Yep.
Okay. Okay, so for these conditions, again, if we see gingival enlargement, that also means that plaque was there, okay? That's why we're getting the gingival enlargement. But note, not everyone who takes those medications will have this, but just be aware that it's out there. It is more common in younger groups. I had a patient, why is this not going? Yeah, I had a patient that looked like this. Actually, hers was a little bit more covered. 6 years old, she was taking seizure medication. Yeah, so it is pretty common in the younger demographic. The onset is usually within 3 months of taking that medication, so they should be taking it for a while before you come to the conclusion, oh, it's because of the medication. Okay? All right. Commonly seen in that anterior sextant, right? So sextant number 2 and 5. Pattern is usually irregular, but first noticed in the papilla. And this is usually due to an increased flow of crevicular fluid from the sulcus. So again, it's a host response thing. They might have some bleeding, but there's no attachment loss. This should be filled in, right?
Yes.
Okay. All right, let's move on to NPI, non-plaque induced gingivitis. So K-Sarah kind of touched on this earlier. This is due to non-plaque reasons. So something else is going on with the patient, okay? So not as common. Plaque-induced is obviously more commonly seen, but if we saw non-plaque-induced gingival diseases, it's typically going to be in lower socioeconomic groups, developing countries, and patients who might be immunocompromised. In this case, again, plaque is not the reason. So if we scaled or did like SRP or whatever it is, it doesn't matter. They're going to have gingivitis or periodontal disease no matter what. Okay. So here's a list of the different classifications of non-plaque-induced gingival diseases. You will touch on all of these things actually in pathology, which is good because they are kind of going to be on your boards, okay? For this class, don't worry about this whole entire list. Just focus on the next few slides, the ones I actually focus on, okay? But you can see some of the origins of these are very different, right? It's mostly going to be like viral, fungal reasons, autoimmune diseases, so non-plaque related. And it goes on. Okay, so we'll start with genetic developmental abnormalities first. So here we have hereditary gingival fibromatosis, okay? So this is, like it says, it's a genetic thing, okay? A rare condition, more rare than drug-related gingival overgrowth, characterized by slow progressive enlargement of maxillary and mandibular gingiva, okay? So this is different from the medically induced one. This is a genetic condition, okay? You can see, I think I do it in the next slide, maybe not. If we were to compare like the gingival, the medicinally induced one versus this one, the texture is a little bit more different, okay? This one's a little more like corrugated kind of, more texture, while the other one's more smooth.
Is that painful for them?
I don't know, yeah.
Have you seen anything like that, Professor?
Not,
Blurring hair?
I have not, no. And it says it's pretty rare. I've seen the drug-induced ones, but not this one. Yep.
So how would you treat that since it's genetic?
Usually what they do is incise it, like cut it off surgically.
Kinda like,
Yes, kind of shave it down. Yes, yeah.
Will it grow back then?
It could grow back. Yeah, same with the drug-induced, it could grow back. Because it's just like a overworking fibroblasts, right? Creating those tissues at a higher rate. Okay, so when I mentioned necrotizing, right? Necrotizing periodontal disease, NPG, this is caused by bacterial infections in patients who already have underlying factors such as poor self-care, smoking, stress, poor nutrition, etc. and it's usually attributed to these bacterium right here. Okay, I wouldn't worry so much yet, but we'll talk about which ones you should kind of flag there. Okay. All right, so with necrotizing periodontal disease, we'll talk about it more, but just some characteristics we're looking for. With gingivitis, it's only affecting the gingiva, right? There's no attachment loss or anything. Excuse me. No attachment loss or anything. How we describe the papilla, it's ulcerated and necrotic. What does the word necrotic mean?
Dead.
It's dead, so dead tissue, and punched out or cratered is the description. Okay, so again, that gentleman that had leukemia, right? That's why this is what the doctor thought he had. Actually looks pretty similar to that other slide with the patient with leukemia. All right, so there's some other rare occasions where bacterial infections could be the root problem of gingival diseases, and these are kind of the less common ones, and we would only know that by doing like a, what's it called? Culture, thank you, yes, little swab, and that's how we would figure it out. Okay, atypical myobacterial infection. You'll see ulceration, cankers, mucus patches, and atypical gingival inflammation as well. So these are kind of more of a rare type of bacteria that's causing it. Okay, so these are going to be inflammatory and immune condition lesions, okay? The ones we really want to focus on here on this list, hypersensitivity reactions, erythema multiforme, lichen planus. I think that's pretty much it for this section.
I have that in my notes today.
Good.
Erythema multiforme.
It's a fun word, right?
Yeah. Sorry, Professor, what was that? Erythema.
We'll talk about erythema multiforme, yeah. Okay. So intraoral allergic reactions. So this has to do with like if you guys are using a new mouth rinse and use new toothpaste or whatever, right? And typically if it has like an additive flavor like cinnamon or something like that, some patients will have a reaction to it, and it could be gingival inflammation. For example, Crest Pro Health is not my jam, right? Every time I rinse my mouth with that, I always get like sloughing in my mouth. Same on my gums, right? They start to like peel and it gets kind of itchy. What? Disclamation, exactly, or sloughing. So that for me and for some of you, it sounds like we're having an allergic reaction, and that actually falls under a gingival, kind of gingivitis category, but it's non-bacterial related. Has to do with the product. All right. Again, it could be a systemic response. Allergic reactions are common in patients who have history of allergies. I am allergic to lots of things, and maybe you guys are too. And people who have skin rashes, like eczema, as I do too. So if they already had history of that, may be likely that they'll get that desquamation or sloughing. Sometimes it'll affect the gums or give them ulcerations in the mouth as well. Okay, I've never had an ulceration. It's just annoying, like peeling and itchiness. But so there can be some variances. I like it though. I like the rinse Crest Pro Health. It's like lighter, but it doesn't like me.
So is it something in Crest Pro Health, or is it just the CPC? Could you use like
I
other
don't know.
CPCs, like Scope has some CPC?
I've been okay with Scope.
Okay.
Yeah, so I don't know.
So you use scope instead of Crest Pro Health?
No, I actually use Closis. Did you guys learn about that one?
We have, and
Yeah.
briefly in preventive,
Yeah. It's kind of like, it's probably why is that so shade? Oh no. No, just because I get like tonsil stones sometimes. And, yeah, so the Closis seems to help.
How do you spell that?
Closys.
That helps with tonsil effect.
It's supposed to, and I've been okay with it. Yeah. You just have to gargle really like intensely. I know. All right, erythema multiforme. That's a fun one to say. Okay, so with these systemic conditions, again, you'll see oral manifestations, but I want you to understand that it's a whole body thing going on, but we need to look for these red flags in the mouth, okay? So erythema multiforme is an uncommon acute immune inflammatory disorder that will affect the skin and of course the mouth, okay? The cause is unknown, but it's thought to be associated with a virus because a patient who has like a breakout or something like that will typically have like a herpetic lesion as well, okay? Same with like Bell's palsy patients, right? When they get that kind of drooping of the face, they'll also have a herpetic lesion that comes about too, which is kind of interesting. So again, unknown really the origin, but they think there's a correlation with herpes simplex virus. Okay, 25 to 60% of these patients with this condition will also have oral manifestations like ulcerations of the gums or crust on the lower lip, right here. So it's a little bit deeper in color, whereas like the ascorbic acid gingivitis, it was kind of gold and around the outer lips. This one's kind of on the inner labial mucosa.
Is it a cleft lip?
Is it a what?
Cleft lip?
I think they're retracting. Or maybe it is a cleft lip, who knows?
So in this picture, we're only looking at the lips.
Oh, yeah, it looks
And the ulcerations of the
And the-
gingiva.
okay.
Yeah. All right, so this is a star glitter. So like I said, it is a systemic condition, right? What do we see on the tissue? So like the previous slide said, it's a skin condition and an oral mucosa condition. On the body, what we will see are these target-like blotches. Kind of cool, but symmetrical red blotches that resemble a target, and they're circular, okay? On the mucous membrane, it begins as blisters and then can progress into ulcers. It can be helped with like a topical steroid, right? But you just want to kind of look out for those. Now that you guys are in pathology, do you always think like, I have that, I have that? All right, the next one is oral lichen planus. This is a chronic autoimmune condition, kind of like the last one, that affects the skin, hair, nails, and mucous membranes. Initially may last for weeks, months, or sometimes years, so it can become chronic. Again, the origin's unknown. It can, it's not viral or bacterial. They don't know what causes it. Okay. The reason why, even though it's a systemic condition, the reason why we want to look out for this is because they are at risk for developing oral cancer. There is that correlation, okay? So if we're unsure, you know, whether or not they have it, we want to look at the patient holistically, right? Obviously, we'll look for the lesions in the mouth, which I'll show you in a bit, but also look at their skin, okay? It's characterized with like more purple in color, like a deeper purple, itchy. They're flat, topped bumps that develop over several weeks. Okay, how does it look intraorally? Okay, so lacy white patches, sometimes associated with painful sores, intense redness of the gingiva. So specifically what I want you to note there, SSGG, is Wickham striae. Wickham striae refers to these lacy white patches. Sometimes your textbook calls it like, lacy, but like a net, right? An intertwined net as well. And this is on the buccal mucosa. It's getting hot in here. Oh.
Do you like reading your
Here we go.
Did you go back?
Yes.
There you go.
Thank you.
Are you guys hot too, or is it
Yes,
just me?
Yeah, it's
I
hot.
feel
The heat is kicking in.
The
It
heater's
is
on.
fine.
fine.
Yeah.
There is only two temperatures in here. It is ice cold and molten hot.
Isn't that crazy? I know.
Dude, it's ridiculous.
I do this all day long.
I can't wait for the summer.
Oh gosh. Will you guys still be here?
Yes.
100%. Oh, 100%. I don't know, this is never going to end.
Oh boy. All right, some other lesions intraorally, papular lesions like a little papule, reticular fibrous net or web-like lesions like we just saw. We can see some erythema, which is redness, ulcers, and then bulbous lesions as well. Okay, so after all that, right, what type of scaling would be appropriate for gingivitis patients? Some will be a prophylaxis, okay? So this would be gingivitis on intact periodontium or if the patient has reduced periodontium but due to non-disease reasons. Who can give me an example of this type of patient? Ortho, very good. And then we can also do perio maintenance on a, kind of weird, gingivitis on stable or stabilizing patient. Who can tell me what patient this is? Successful SRP, maybe relapse a little bit, but there's no progressive bone loss. Very good. Yeah.
Is that for, like, the perio follow-up, is that the time frame where we would know if it's like stabilizing or stable?
Correct.
Okay.
Yep, exactly. So either at the reevaluation, but we also evaluate every time they come in for a PM.
Mhm.
It's a really good question. All right, you guys good here? Okay. All right, let's move on to periodontitis. So that was all gingivitis and all the different types, right? Essentially, when you guys are doing your diagnosis in clinic, you're just gonna write generalized gingivitis. But it's still important to know the origins of why, right? Is it bacterial? If it is bacterial, why is it so bad? Is there something else going on? Is it non-bacterial? If there's no plaque present, then why are we still having these conditions, right? So you still have to critically think those, but when you're writing your patient presents with, you're just gonna say gingivitis or plaque induced, okay? And you still have to know all that stuff for boards too. All right, so let's move on to the second type of periodontal disease, which is periodontitis. So we wanna look at those clinical signs. We're gonna look at CAL, clinical attachment loss and its significance, warning signs of periodontitis, progression seen in periodontitis, and then meaning of the descriptors recurrent and refractory. All right, so here's where we're at on that chart, right? You have your umbrella term right here. We're gonna start here and then we'll talk about those other ones in the next few weeks. Okay, so periodontitis by definition, we have the bacterial infection that triggers the host-mediated inflammatory response. Unlike gingivitis, all the parts of the periodontium are being affected, okay? And gingivitis, what part is being affected? Just the gums. Now we're affecting everything, right? So the gums, the ligaments, the bone, and the cementum. Okay? It's considered to be the #1 reason of tooth loss in adults, especially smokers and patients who have uncontrolled diabetes. Like the slide last week said, approximately 47.2% of adults over 30 suffer from periodontitis. Okay. And this is just some verbiage. According to the CDC, this is their definition, right? So here are some kind of interesting statistics. We said 47.2, 30, if you're over 30 years old, you'll probably have some form of disease, periodontal disease, but it increases with age, right? When we hit that 65-year mark, 70% of adults will have periodontitis, according to these stats. When we talked about prevalence, right? Who's it more common in, men or women? Men. See, so 56%, 56% men and 38% women. I didn't mean it like that. And then of course, kind of their socioeconomic status, their education level, and it's very, very prevalent in smokers as well. All right, so true or false? Gingivitis will always become periodontitis.
False.
That is false, right? But on the other end, periodontitis always started as gingivitis. Does that make sense? Okay, so that depends on how poorly they're doing with their home care and what their host response is like. So based on those two things, the bacteria and they're not messing with it, and their host response, that will then transform that gingivitis into periodontitis, okay? So, yeah, host susceptibility. What is this saying? Once a perio patient, always a perio patient. We talked about that last week. All right, you guys okay here? Okay. So distinguishing features of periodontitis, obviously bone loss, connective tissue loss, but that key thing that we're looking at is that clinical attachment loss, and then the verbiage that your board exam likes to use is apical migration of the junctional epithelium, right? That is that key characteristic there. Other clinical signs and symptoms, this should be hopefully are familiar with, right? Swelling, redness, bleeding, pocketing, bone loss. Other things we will start to explore, mobility. We'll start checking for suppuration or pus, that infection. We are already looking for deposit and plaque in calculus. Okay, so when we are doing our assessments on our patients, these are the things we are always looking for. Your gingival description, color, texture, tone, all of that. We want to look for BOP, but also, are the gums swollen? Meaning, is there a lot of crevicular fluid going to the gums causing it to swell? In addition, is there exudate or pus? Because that tells us there's active infection. We do our calculus detection, right? We do our probing, we check our loss of attachment with recession. We want to say if it's localized or generalized, and then we look at the patient as a whole. Are there contributing factors? Are there other symptoms that the patients are sharing with us that kind of point us to this diagnosis?
Can we see crevicular fluid? Will we know what it looks like?
No, it's manifested as gingival inflammation, swelling, edema. It's within the tissues. Okay, so sometimes with the symptoms, we want to educate our patient. It's typically painless, right? Especially if it's become so chronic. So they might be unaware of the disease and therefore they're not going to want to get it treated. I don't feel it, I feel fine, I don't want to get it done, right? But you need to let them know it's kind of like blood pressure. You don't feel it, but that could still be really dangerous. Some patients, however, are pretty in tune with their body, so they might share out with you, you know, this is what I'm feeling, right? Or I noticed this. So a lot of times patients will talk about, I'm getting food stuck in here. I never got stuck there before, like what's happening, right? And it could be for all sorts of reasons. Maybe the teeth are shifting, or they had lost bone in that area, or lost tissue. Oh, my teeth are really sensitive now. Why is that? Because there's lots of recession now, okay? I have a pain in the jaw that could be due to an abscess or other pathology. I notice there's spaces in between my teeth. Again, shifting of the teeth, they're losing ligaments, they're losing support, so things are starting to move. Okay, so typically yes. Okay, so although clinical signs of periodontitis can be pretty obvious, sometimes the clinical appearance of tissues is not a reliable indicator, right? Meaning, sometimes we think, oh, they're pretty healthy, but in some situations, they may not be. For example, a smoker, right? We might be deceived. Or if they have periodontitis for 20 years, bless you, it might be chronic, but this is not a reliable indicator, okay? So remember where we said gingivitis is a clinical diagnosis where we have to see it with our eyes. Periodontitis, we have to actually go the opposite route. We need to look at our assessments and our x-rays, okay? Because this looks pretty healthy, yeah? Pale pink, stippled, filled embrasures, but we stick a probe in there, and then this is what we get, okay? So again, we cannot just rely on that gingival description. All right, so we'll start with this clinical symptom first, bleeding, crevicular fluid, and exudate. So bleeding is very, very common in periodontal disease, gingivitis, or periodontitis actually. It can be spontaneous when they're brushing or during probing, right? There will be an increase of gingival crevicular fluid or separation from the pockets if they are diseased, okay? Have we talked about crevicular fluid at all, or have you in other classes? We'll talk about it more, but do you guys know what crevicular fluid is within our tissues? Okay. Okay. You guys remind me of my daughter. She's doing this a lot now. I don't know. So crevicular, I know, same girl, same. The crevicular fluid is in your tissues, right? But if you're sick or diseased, you start to like produce a lot more crevicular fluid, which spills into the pockets, and that's why we get swelling and things like that, okay? So with periodontal disease, we know there's an increase of crevicular fluid to kind of answer Amanda's question, and we can't see it, but the fact that there's so much swelling, it's kind of understood, okay? All right, deposit. So oftentimes in periodontitis, we will see kind of mature calculus that's present, meaning it's been there a long time. It can vary though, they can be thick, they could be little spicules, ledges, rings, right? And just depending on the host response, the reaction to that size of calculus, no matter how small or how big, the host response determines how quickly the disease progresses, okay? So the pathogenesis or rate of progression relies on our host response. This is the big thing with periodontitis. This sets it apart from the other diagnoses, okay? Which is clinical attachment loss, or CAL. Remember you guys, now it's freezing, right? With your clinical findings assignments, CAL is one of them, okay? So clinical attachment loss is a measurement of the amount of destruction affecting the tooth supporting structures. We are looking at the junctional epithelium. Has it migrated apically? Are we destroying gingival fibers? Are we destroying periodontal ligament fibers? Are we losing bone? All of that plays a role in CAL and the measurements. Okay, so clinical attachment loss of 1 to 2 millimeters in at least one or several sites is found in most of our population, okay? These individuals can potentially exhibit all of these, but not always. Okay, so just keep that in mind. Okay, how do we measure CAL? There's going to be a few different ways. The most common one is recession, right? Whenever we are measuring CAL, we use the CEJ as a point of reference, okay? So if we look here, right, maybe on your PowerPoint or on your iPad it looks better, but do you guys see this line right here? That's your CEJ, okay? So we usually will use that, so the point where the enamel meets the cementum, your CEJ or junction, we use that because it never moves on the tooth, okay? It should stay put. And then from there, that's where we measure. Where is your margin? Where is your recession? Is it really above the CEJ? Is it really below the CEJ? Where is the furcation relative to the CEJ, right? Where is the bone level relative to the CEJ? So that's an important reference point there. Okay? That probe is gone.
Yo, no lies.
That is a good point. So that's about a probably 16 or 17 millimeter pocket.
Well, the next picture shows why.
I know.
There you go. Okay. This is fun. Yummy. All right. So again, probe readings are just one indicator. Remember we talked about it could be a pseudo pocket or a true perio pocket. So this we could be, I don't know, maybe it's just medication, right? But then when you do a gingival flap and open it up, there's a bony defect here. This looks like an osseous crater, right? And that's why you have that really deep pocket.
Oh, crater, makes sense.
After the quiz. All right. Localized.
One wall?
That's a no wall, I think. Localized versus generalized. Again, when you're doing your diagnosis, we have to say, you know, it's on this specific quad or whatever it is, especially when you guys are trying to hit those requirements, right? Sometimes you'll have a patient who's generalized gingivitis, but one quad of stage 1 periodontitis. So you need to be specific with those diagnoses, okay?
I have a question. I've heard professors say like, oh, if it's one quad, then it, like in private, you're just gonna call it perio.
Right.
But so, is that not what we do? We're not gonna do that.
We don't do that.
We're gonna.
Here we diagnose correctly, specifically how they're presenting,
Okay.
right? So if it's a localized, if only 2 and 3 have bone loss, but everywhere else is gingivitis, we're gonna call it as it is.
So we're gonna.
In private practice, it's because of insurance, right? You can't do an SRP and a prophy on someone. You just have to call it a generalized thing.
So here we diagnose by quadrant or by tooth?
You look at the biggest picture the big picture first. This probably we'll get to there, I think,
Okay.
hopefully. You look at the big picture first. If it's really just one outstanding thing, you probably would just go with a generalized diagnosis. But if it's like a whole quad versus the rest of the mouth, you can call this quad stage 1 and the rest is gingivitis.
Okay.
So I would say everything is situational, kind of case by case, because it depends on how that patient's presenting.
Okay.
Yeah, it's a hard one to answer. Yeah, Kendra?
So just like a little, I don't know, comment
Uh-huh.
from clinic early, because sometimes I'm like 30% with 30%, what's more or less, but Professor Y kind of split it up for Christina and I. She's like, look at the mouth, divided in half, like your top arch is 50%, your bottom arch is 50%.
Another half, yeah.
Linguals, 25%, buccal, 25%.
Yeah.
So she's like, if they have inflammation on all the linguals and a couple spots here and there, she's like, then you're, you know, at the 30 or over. So
Right.
it's like, oh, when you break it up like that,
I like that.
it's easier to kind of, like, mathematically
Yes,
see where you're at.
that's a really good point. Thank you for sharing that. Yeah, so just kind of break it up into a way that makes sense to you. Good, I like that. All right, so when we're looking at extent progression, so yeah, we were talking about less than 30% localized, more than 30% generalized. Progression is the change or advancement of periodestruction. So this will make sense when we start grading our patients. So we give them a diagnosis, then we say grade A, grade B, grade C, and that tells us, you know, how slow or how fast things are going. All right, so with the progression, tissue destruction tissue destruction in untreated periodontitis doesn't affect teeth evenly and sometimes can be site specific, like that intermittent theory said. Sometimes sites will go and change for a long period of time, and others, all of a sudden, you'll have really rapid bone loss. Like gingivitis, a lot of the disease will occur interproximally, because that's where the patients tend to forget about or not floss. Okay, some contributing factors we need to consider. Let's see here. Yeah, more systemic stuff like, for example, HIV, or local intraoral factors like crowding, overhanging, restorations, etc., or smoking as well will obviously play a role in how bad the perio disease is and how susceptible the patient is to the disease. Okay, so these terms are important terms to know, okay? We're gonna look at the definition between recurrent and refractory, and then after that, we'll go through the staging process. Okay, so just a heads up, these forms of periodontitis are no longer recognized by the 2017 classification system, so we don't say this is recurrent periodontitis, this is refractory. We just stage it right away, but for your board exam, they expect you to know these definitions, okay? So, yep, it's just important to know what the patient is going through. The first one is recurrent periodontitis. When you hear the word recur, what do you think? And it's back again, it's happening again, exactly. So return of periodontitis, even though it was stabilized and arrested by scaling. So we were good, but all of a sudden it's reactivated. Reasons why? Typically it's because the patient's not doing their home care or they're not coming back for their maintenance appointments, okay? So usually that's the cause there. Here's an example, right? The dental practitioner and the patient need to arrest disease with appropriate periodontal treatment, maintenance, and self-care. But if they don't do that, that's when the disease will recur. Refractory, on the other hand, is really sad. Actually, with this diagnosis or condition, I should say, periodontitis in a patient who has been monitored over time, who exhibits continued attachment loss, even though they've done their SRP, they're coming in every 3 months, and they're doing really, really good home care. It's just something else is going on that the loss continues, okay? I had a patient like this. She was immunocompromised or had an autoimmune disease. I want to say it was lupus, but maybe something else. She would come in every 2 months and pay the $120 every 2 months or whatever it is. And she would go to Perio as well. But even between the two of us, she was still getting that bone loss. It was just, yeah, she was trying everything she could. But it wasn't, I guess, for nothing, because if she didn't do that, it'd be faster, right? So you can kind of look at it that way too. The cause of refractory periodontitis is unknown, but it can be due to complex contributing factors. Again, like I mentioned, the therapy can slow it down, but doesn't resolve it. The control of periodontitis in this situation is not possible. So she will continue to get bone loss, but at least we can kind of slow things down. Yeah.
For patients like that, where like, are they headed towards dentures, like 100% because the disease will continue to eat their bone?
You know, not necessarily. She was in her early 60s and still had all of her teeth.
Okay.
It was still progressing, but a pretty slow rate.
Okay.
So not guaranteed, but if she hadn't been coming in every 2 months, possibly.
Right, so
Yeah.
should we like determine the rate of that and then kind of just discuss and like let them know, hey, maybe you'll need dentures or like that sort of thing?
Not
Or
our place
don't
to
touch
say.
it? Okay,
Yeah,
got it.
maybe the dentist might touch on that. That's a good question though. It's just not our scope.
Okay.
Yeah. Okay, so refractory periodontitis, appropriate periotherapy, doing your perio maintenance, but cannot be controlled, and you just kind of see the bone loss progressing over time, right?
Would genetics like play a role in that possibly?
I would say maybe, but it's usually because there's an autoimmune disease. Yeah. All right. So we'll probably finish up here, and then staging and grading, okay? All right. So when to diagnose someone as officially being a periodontitis patient? So according to the classification system, if there's interdental cal in 2 or more adjacent teeth, so it can't just be one tooth, right? If it's one tooth, it's probably just a defect of some sort, but it's affecting 2 or more adjacent teeth, or if 2 or more teeth exhibit clinical attachment loss with pocketing greater than 3 millimeters on facial or lingual. That would be a true perio patient. When they are a true perio patient, that's when we start to diagnose them. Okay, so again, it has to affect more than one tooth, right? But also, if they have clinical attachment loss, it cannot be because they brushed too hard, right? It cannot be because the cavity is extending so low. That's what's causing the recession. It can't be because of a bony defect, like they extracted their 3rd molar, like I mentioned my husband, right? He'll always have a 7 millimeter pocket back there. Can't be because of an abscess or fractures. So if they are exhibiting clinical attachment loss because of any of these reasons, they're not a true perio patient. It's something else going on. In order to really diagnose someone, it has to be bacteria related, right, and affect more than 2 teeth. So here are the main forms of periodontitis. Obviously, we're going to start here, but these are some variances. So necrotizing perio and perio as a manifestation of systemic disease. Okay, and this is the 99 system. All right, so how do we classify a patient? We use stage 1, stage 2, stage 3, stage 4. This is for periodontitis. Once upon a time, they used case typing, okay? So the reason why they switched over to staging was it models after cancer diagnosis. The thought is, if we stage it like that, the patient will understand it a little bit more, right? How it progressively gets worse, but also maybe they'll take it a little bit more seriously. That was a thought process behind it. If they are healthy or gingivitis, we just call it healthy or gingivitis. Then when we start to see attachment loss, then we stage them. Does that make sense? And it has to be active periodontitis, okay? The staging is going to be based on severity and how complex it's going to be to scale them. And again, this is just a side note. That's what I was asking Jordan last week. Case 1 before was gingivitis. Case 2, 3, 4, that would be periodontitis.
I think that's what it was.
Maybe,
I think
yeah.
that makes sense.
All right, so when we are staging periodontitis, some other factors include, we are going to look at our perio assessments. So furcation, clinical attachment loss, radiographic bone loss, and then of course tooth loss as a result of periodontal disease. All right, so stage 1, characterized by initial stages of attachment loss. Stage 2, established periodontitis. Stage 3, severe periodontitis with significant destruction to the attachment apparatus. Stage 4 is very advanced. So here we have tooth loss already and possible loss of the entire dentition. This is a very good slide to know, okay? So this is how we break down the periodontitis staging. Yep, so this is the textbook version, which is also in this handout if you wanted to print it out. So this is this, okay? So it kind of explains what to look for and how to stage your patients, okay? I also put the AAP version as well, so they have a little bit more verbiage. But basically what we're looking at interdental cal. So clinical attachment loss in between the teeth. This does not mean the probe depths, okay? this means they have 1 to 2 millimeters of recession, right? They have 3 to 4 millimeters of clinical attachment loss, whether it's recession or something else. Does that make sense? So this is not their probing. Yes.
So like recession from like the CJ line to the
Correct.
line to the
Exactly.
okay.
Yep, that would be your millimeter measurement.
Okay.
Good. Yeah.
Is Cal exclusively, like measured by, is it exclusively measured by like gingival recession, or is there multiple things that fall under the category?
Good. There's multiple things that fall into the category. The way we use it in our clinic is recession because it's the most visible thing. But you also would consider the ligaments and things like that too. Okay, so interdental cal, we are also going to look at radiographic levels too. So how far on the tooth is it happening? Is it in the coronal third, middle third, or to the root, right? That's going to be considered. Tooth loss, have they lost 4 or more teeth due to periodontitis or whatever it is? Here's your probing depths, okay? Then we have bone loss, and then if there's any other reasons, that's more for stage 4. Yeah, Tony?
Just to make sure,
Mhm.
interdental cal is only for gingival recession only here in the clinic, but when we go out to the real world, we can measure it and like.
I don't know any other
Or-
office that goes beyond recession. I've never worked in a perio office, but maybe they do more. I know what we do here is just recession and then mobility too. Yeah, but that's the most visible thing we measure.
That makes sense.
Yeah, okay. All right, there are also some questions. What if we're here, here, and here, right? You always go with the worst diagnosis, okay? So you take the tooth that has the worst and you go with that, okay? Okay, so based on their staging, this is the prognosis. It's pretty generous, I think. So stage 1, stage 2, their prognosis is still pretty good, okay? Meaning they'll probably keep their teeth and we're okay. Stage 3, which is severe periodontitis, there's still a pretty fair chance they'll keep their dentition. And then stage 4, the prognosis is very questionable at that point, meaning they're more than likely going to lose some teeth. All right. As I mentioned earlier, we also want to take note of how quickly the disease is hitting the dentition, so we grade them. So you might see something like stage 1 grade A, right? Stage 1 grade C, okay? The grading system talks about the progression of periodontitis. Is it slow, moderate, or really, really fast, okay? We base this grade on evidence that is direct evidence or indirect evidence. For example, direct evidence would be, we have FMX from 2010, another FMX 2013, et cetera, et cetera. So we can actually compare, right? And we can see that bone loss. Indirect would be assessment of bone loss of the worst affected tooth depending on age. So let's say there's a new patient in clinic. They've never been to the dentist. They're 20 years old, right? It's been 20 years since I've ever sat in a dental chair, okay? How are we to know what their bone progression looks like? Instead, what?
Nothing,
No.
sorry.
It's okay. So instead what we're gonna do is they have a formula we can use based on their age. Okay, so that would be indirect evidence. Okay. Other things we need to consider when we're grading them, their lifestyle choices, right? So grade modifiers could be like if someone smokes. Are they smoking half a pack? Are they smoking a pack, right? That would be a grade modifier. So for example, someone is a stage 1 grade A, but because they smoke about less than 10 cigarettes a day, we automatically bump them to a grade B. Okay, so that would influence the grading as well. Okay, so again, slow, moderate, rapid, moderate, and then rapid rate of progression. And this is a good kind of summary of showing like what would be an A, what would be a B, what would be a C, okay? So this too is in this little handout. So if you're in clinic wondering how to grade your patient and stage them, this should be handy for you. They have them in each operatory as well, so it's there, but it's up to you to figure out how to read it, okay? Okay. I think I'm gonna wrap up there. Yeah. So we'll stop here. This is just summarizing this chart right here. So we'll wrap up at grading. So what slide are we on?
130 and 142.
Oh, not bad. Okay, so the quiz will stop at slide 129 for next week, okay? Then next week we'll finish up the rest of this diagnosis. In your spare time, I would encourage you to watch these videos. We'll watch them again next week, but it's a good explanation, okay? And then we'll continue with our Oh, and just a side note, if you're able to, let's go over these recaps really quick because they might show up on the quiz. Really quick, this patient is 3 months pregnant. What is this lesion presented? Pyogenic granuloma. How do we know it's not ascorbic acid gingivitis? Very good.
And she's pregnant.
All right, and she's pregnant. Good. You have completed an SRP for a stage 2 perio patient. You've done a marvelous job. Looks like the patient is also doing their part with home care based on DIS. They're back for their reevaluation. The pockets are aggressively deeper, even faster. What is their condition that's happening?
Refractory.
Refractory periodontitis. Very good. So if I give you a case scenario, is it recurrent? Is it refractory? Okay. Inflammation can often be associated with systemic. What is this called? Begins with a W. Wicked. Wickham striae.
Wickham striae.
And what condition is it associated with? Oral lichen planus. Very good. Yes. All right. Identify at least 3 other classifications of non-dental plaque-induced gingival diseases. So if it's due to fungal, viral origins, if it's genetic, if it is a hypersensitivity or an allergic reaction, or if the patient has autoimmune disorders. Okay? All right. So you don't have this. I'll leave that up there. All right, guys. Thanks again for coming in this afternoon. Have a good weekend, okay? Thank you.
Get in there.